Hi everyone. Am I audible? Am I visible? Am I audible and visible? We will start with our session, and I wanted to discuss some 10 very easy questions that are asked in INICET, predictable questions, and we are going to discuss them over the next 30-35 minutes. So just give me a thumbs up if you are live, and I'm going to start. Okay, hi Swati. Wonderful. Good evening everyone. So we are going to start with the INICET Predictor series, and we know INICET has this specific predilection for certain topics, certain type of questions, and we are going to discuss them one by one. Am I audible and visible? If yes, just give me a thumbs up and we will start. The first question, very good, is the best marker to know the ET tube is in correct position. The best marker to know whether ET tube is in correct position. So, what do you think? Yes, the answer is end tidal CO2. Is oxygen saturation a good marker for ET tube position? No. It cannot even be called as a surrogate marker because hypoxia doesn't mean your tube is not in the correct place, and if you don't have hypoxia, it also doesn't mean that your tube is in the correct place. So this is out. ECG, is it a marker of the correct position of the tube? No, it has got no relevance to the position of the tube. Now the question comes, what to choose between the two. So just tell me what according to you should be a better criteria. A objective criteria or a subjective criteria? End tidal CO2 is an objective criteria which is based on a machine. It is an objective criteria that is based on a machine, while auscultation is a subjective criteria. Auscultation is a subjective criteria. So what will you prefer between objective and subjective? Always objective criteria. But suppose there would have been in the option, apart from end tidal CO2, suppose they would have given fiber optic bronchoscopy. Then tell me what you would have chosen. Between end tidal CO2 and fiber optic bronchoscopy, what would you choose? Between end tidal CO2 and fiber optic bronchoscopy, what will you choose? So remember, the gold standard for correct position of endotracheal tube is fiber optic bronchoscopy. So it is considered to be the best. Now in this question, we did not get fiber optic bronchoscopy, and that is why we chose end tidal CO2. End tidal CO2 is most common used technique. Most common used technique. All right. Why do we want to know the correct position of the endotracheal tube? It helps us in avoiding hypoxia, because if your tube is not in the correct place, that means it is not in trachea. Then it is in which place? It is in esophagus, and if it is in esophagus, then it can cause hypoxia. Also, there is a risk of aspiration. Okay, there is a risk of aspiration. Now tell me, is having end tidal CO2 the only criteria? Only presence of EtCO2 waveform is the criteria for correct position of endotracheal tube, or there is something else in it? What do you think? Is only presence of endotracheal tube the criteria? The presence of end tidal CO2, sorry. Suppose the waveforms are dwindling to 0, then will it indicate presence, correct position of the tube? No. So remember, it has to be persistent capnography. It has to be persistent capnography, sustained capnography. Because if it is going down to 0, ill-sustained capnography, if it is ill-sustained capnography, then it will indicate esophageal intubation. then it will indicate esophageal intubation. That is the importance of sustained capnography. So remember, the criteria for correct position of endotracheal tube is sustained capnography. All right. All right. Wonderful. Let's move on to the second question. The accuracy of pulse oximetry can be significantly reduced by all of the following except. The accuracy of pulse oximetry can be significantly reduced by all of the following except. See, whenever I get an all except type of question in the exam, I always write the what I have to find in the question, whether a true statement or a false statement. So reduce in the pulse oximetry reading except means which doesn't affect or increases. False high reading. That is what we need to know. Intravenous bolus of methylene blue. Tell me, will it increase it or decrease it? Obviously, it is going to decrease, and methylene blue causes maximum decrease in pulse oximeter reading, makes it 65%. So this cannot be correct answer. Intravenous bolus of heparin. Intravenous bolus of heparin. Heparin is a anticoagulant. Do you think it should have any effect, reduction effect on the pulse oximeter reading? No. Blue nail paint, it is going to decrease the reading, so cannot be. Low blood flow, hypotension will decrease the falsely low the reading. So the correct answer is intravenous bolus of heparin. Intravenous bolus of heparin. Tell me, what is that condition where you get a false high reading? Where you get a false high reading. What is that condition where you get a false high reading? Where the actual O2 saturation is lower, but what you see on the monitor is always higher. Where would you get false high reading? Yes, very good. There is only one example, carboxyhemoglobinemia. Carboxyhemoglobinemia, COHB. Carboxyhemoglobinemia. Very good. Now, this is a very interesting question. Question number 3. A case of head injury with subdural hematoma, SDH, with high intracranial pressure going for surgical drainage. Which anesthesia will be used? Now, forget about the options. First, tell me, if it is high intracranial pressure and the patient is going for surgical drainage, that is decompressive craniectomy, first tell me what would be the ASA grading of this patient. What would be the ASA grading of this patient? American Society of Anesthesiologists, PS, physical status grading. What would be the ASA grading of this patient? Okay, Swati is saying 3C. You are saying 4. Divyanshu is saying 4. So justify, Swati, 3C. What is the criteria 3C? 3 is a severe systemic disease that is limiting but not incapacitating. Does it look like a severe systemic disease? Is SDH, head injury, a systemic disease? 4 is a severe systemic disease that is life-threatening. Is it a severe systemic disease? Do patients are born with high intracranial tension? Are they born with trauma and SDH? What does this look like? Is this a comorbidity with the patient, or is it something that has been acquired by the patient? Only Harshal has tried to understand it here. It is high intracranial pressure because of trauma. This is ASA 5. Moribund patient not expected to survive without surgery. ASA 5E. Isn't it? Because here doing the surgery is life-saving for the patient. Now first tell me, if it is a raised ICP patient, what would be your choice of anesthesia? Would you prefer using an IV agent for maintenance of anesthesia or a inhalational agent for the maintenance of anesthesia? An IV agent or an inhalational agent? What would you prefer? Very good. You will prefer TIVA. So high intracranial pressure. Your choice of anesthetic maintenance would be TIVA over inhaled. Very good. Now tell me, in TIVA, what would be your choice? Raised ICP. What would be your choice? In TIVA, what would be your choice? Which agent will you prefer for TIVA in raised intracranial pressure? Always remember, thiopentone is preferred over propofol for raised ICP. And in inhalational agent, SIVO is considered to be the best. Now look at the options. Iso, halo, ketamine, thio. Out of which you cannot use, should not use. Ketamine increases ICP, halothane increases ICP, isoflurane increases ICP, thiopentone causes maximum decrease in ICP. It causes maximum decrease in ICP. Alright, I have given you a very nice table of both the neurophysiological properties, cerebral blood flow that decides the intracranial pressure and cerebral metabolic rate for oxygen. Okay. Now, if you look at IV induction agents, all decrease cerebral blood flow except ketamine and all decrease CMRO2 except ketamine. So ketamine is the agent that should not be used in neurosurgery, both for the reason that it increases ICP as well as it increases CMRO2. But if you look at inhaled anesthetic agents, all agents with no exception increase your ICP. But except nitrous, all are neuroprotective. And in that, sevoflurane is associated with least increase in ICP and maximum decrease in CMRO2. So in inhaled anesthetic agents, your choice would be sevoflurane. All right. The Dibucaine number in a patient having heterozygous atypical plasma cholinesterase will be. Tell me, this question belongs to which chapter in anesthesia? This question belongs to which chapter in anesthesia? Specifically pertaining to which chapter? What is SMR? What is SMR? Yes, skeletal muscle relaxants. And when we are talking about something called as Dibucaine number, then which muscle relaxant are we talking about? Which muscle relaxant are we talking about? If we are saying Dibucaine number, then which muscle relaxant are we talking about? Malignant hyperthermia? Gajendra, tell me, how do you know about malignant hyperthermia by looking at Dibucaine number? You got confused, है ना? You got confused. That is why I asked it. Because whenever you get a question like this, nothing is very clear. In the first instance, a question like this will not even appear a anesthesia question. But we know when we talk about Dibucaine number, then we are talking about scoline, and specifically the part of scoline where there is increased duration of action of scoline. And for that, we need to know what is the normal duration of action of scoline. Can anybody tell me? Normal duration of scoline? Normal duration of action of scoline. Rohit, listen to the question very carefully. I am asking you normal duration of action of scoline. I am not asking you what is normal Dibucaine number. I am asking normal duration of action of scoline. Less than 30 minutes, Mukti is probably the duration of action of 90% of muscle relaxants that we use. Yes, duration is less than 10 minutes, making it fastest and shortest muscle relaxant. Fastest and shortest muscle relaxant. All right. So whenever there is a factor that increases the duration, you need to know about it. And atypical plasma cholinesterase enzyme is one of the reasons for increased duration of action of scoline that is identified by Dibucaine number. Now tell me what is normal Dibucaine number. Normal Dibucaine number, that is Dibucaine number of a normal enzyme. Yes, 60 to 80. Then you have atypical enzyme. So when you have atypical enzyme, your Dibucaine number decreases. There are two types of atypicality: heterozygous and homozygous. Heterozygous is a milder form of abnormality, so Dibucaine number is 40 to 60. Homo is a severe form of abnormality, so Dibucaine number is 20 to 40. So here the question is, patient is having heterozygous atypical plasma cholinesterase, so the correct answer would be 40 to 60. The correct answer would be 40 to 60. Is this clear? Is this something that you are able to understand? I have not written the word scoline very specifically to confuse you in the exam. Okay, this question belongs to which chapter, which subject? Because suddenly there is Dibucaine and then suddenly there is plasma cholinesterase and it doesn't add up. So that is why I have given you this question. Interesting question. Question number 5. A 75-year-old man, American Association Anesthesiology Class 3, with a history of coronary artery disease, chronic renal failure, obstructive sleep apnea, is taken to operating room for inguinal hernia repair. He has been seen by a cardiologist and cleared for surgery. General anesthesia via LMA is considered with maintenance using desflurane. Vital signs are normal pre-op and induction, and placement of LMA was uneventful. 10 minutes later, during the surgical prep, the patient's vital shows heart rate of 115, BP of 148/96, respiratory rate of 14, EtCO2 40, and SpO2 99. The end-tidal desflurane value read 8.5, and the only other medication administered at this point of time was cefazolin. What is the most likely cause of patient's clinical condition? Without looking at the option, can you tell me what is your diagnosis? What does it look like? What does it look like? I know it's difficult, but at least I want some differentials from you. Doesn't matter whether they are going to be right or wrong, but I would expect you to think what is happening and letting me know. Reaction with antibiotics, very good. What kind of reaction are you expecting, sweetie? I mean, sweetie Goyal. Malignant hyperthermia, very good. That is one of the very good things. Desflurane, volatile anesthetic agent, and hypertension, tachycardia, but very slight increase in a very slight increase in EtCO2, isn't it? No, antibiotic is okay. I have told you that I have given antibiotic, Jad boy. What about it? Saurabh, don't give me a second year answer. Drug interactions. What drug and what interaction? Side effect of anesthesia. Anesthesia, does it cause any side effect like this? You have to describe that side effect. But I'm very happy you are thinking in the right directions. You are thinking it could be because of the drugs that have been given. That is what you are thinking, isn't it? You are thinking about the drugs that have been given. Now let's look at the options. Rapid administration of desflurane, malignant hyperthermia, insufficient depth, and allergic reaction to perioperative antibiotic administered. So without looking at the options, all of you wrote about these options only, isn't it? All of you wrote about these options, yes or no? That is what I wanted. That do you have a clinical understanding of what we are doing? Now tell me, can it be malignant hyperthermia? If it is malignant hyperthermia, then you will see sudden abrupt rise of EtCO2, that is too high, 40 is normal, and you will see hypoxia. So it cannot be malignant hyperthermia. Insufficient depth of anesthesia could be a possibility if the end tidal desflurane is not reading 8.5. This indicates it is adequate because the MAC of desflurane is 6.6. So even this is out. Allergic reaction to perioperative antibiotics. Very good. If it is an allergic reaction, that is, it is an anaphylactic reaction. You will see hypertension tachycardia or you will see hypotension tachycardia. Tell me, hypotension tachycardia, what will you see? Allergic reaction is releasing histamine and histamine causes hypotension. So you will not see hypertension and tachycardia. You will see hypotension tachycardia. Rapid administration of desflurane. Can it cause this effect? Yes. Desflurane is an indirect sympathomimetic agent. So if you are using desflurane, then there is always a rapid and transient rise of heart rate and blood pressure. Rapid and transient rise of heart rate and blood pressure. All right. So even if you did not know this fact, if you start ruling out 1 option, you will still be in a state to mark option number 1. So sometimes in your exam, you might not get the exact question or the exact option that you know, and still you can find out which is the best possible answer. Still you can find out what is the best possible answer. That is why I said interesting question. Which of the following system prevents the wrong cylinder being attached to anesthesia machine? Straightforward question. Can anybody tell me the answer? Which system prevents wrong attachment of cylinder to machine? Yes, it is pin index safety system. And which prevents wrong attachment of pipeline to machine? Diameter index safety system. Diameter index safety system. Okay. This is how they look like. This is a system of pins on the anesthesia machine and their corresponding indexes in the neck of the cylinder, and they have specific numbers. This is diameter index safety system or DIS, which is for pipeline. Now, question number 7. A patient underwent anesthesia with halothane for maintenance agent. He developed hyperthermia. What additional drug can cause this effect? Now tell me, what does it look like? Somebody was under anesthesia and developed hyperthermia. What does it look like? Somebody under anesthesia and developed hyperthermia. What does it look like? Now, this is malignant hyperthermia. And malignant hyperthermia is a trigger-based event. And there are only two triggers. What are the triggers? Choline and volatile anesthetic agents. Choline and volatile anesthetic agent. Already you have given volatile anesthetic agent. Another agent that can cause is choline. Can you tell me what is the agent of choice for management of malignant hyperthermia? Agent of choice. Yes, dandrolin sodium. Which is a skeletal muscle relaxant. Question number 8. A patient underwent cardiovascular collapse following a regional anesthetic block with bupivacaine. What would be the immediate management? First tell me the diagnosis, then tell me the management. A patient underwent cardiovascular collapse following a regional anesthetic block with bupivacaine. What would be the immediate management? First tell me the diagnosis, then tell me the management. Yes, I understood that the correct answer is C. But what is your diagnosis? Yes, it is CVS last. Very good. Diagnosis is very important. CVS last. Local anesthetic systemic toxicity, that too CVS toxicity. And the correct answer would be intralipid. That is a 20% lipid emulsion. It is a 20% lipid emulsion. It's a 20% lipid emulsion. Okay. And this is a very, very important question in the exam. Very important question. All right. Question number 9. A chronic obstructive pulmonary disorder patient is admitted to ICU and he is on oxygen therapy with face mask with 2 liters of oxygen. He is found to be hypoventilating and his PCO2 on blood gas analysis is 65 mmHg. What is the best strategy for this patient? What is the best strategy for this patient? What will you do? Intubate and start on ventilator, decrease FiO2, increase FiO2, start BiPAP. You would intubate. Vinitha, you will intubate directly. Patient is on face mask. He is hypoventilating, retaining CO2 and is COPD. Will you straight away immediately intubate the patient? Will you intubate the patient? No. You never intubate the patient unless and until you cannot put them on BiPAP or non-invasive ventilation. Decreasing FiO2 anyway is not the option, but what is the point of increasing FiO2? This is a COPD patient who is hypoventilating. Even if you give more oxygen, it is not going to bring down the CO2 because the respiratory drive is O2 dependent. The best approach is to start NIV using BiPAP, which is bilevel positive airway pressure. It helps recruitment of the alveoli and helps in type 2 respiratory failure, and this is the most important indication of NIV: reduction of respiratory workload, acute respiratory failure, and acute hypercapnic exacerbation of COPD. And that is the example where we get maximum questions in the exam. Acute hypercapnic exacerbation of COPD, which is what your patient is having. Okay, but if you look at the contraindications of NIV, only when these things are present is when you should consider invasive mechanical ventilation. Only when these things are present, then you should consider invasive ventilation, that is respiratory failure. Matlab, these are indications. So when they are not present, okay. So if there is immediate threat to life, then it is a indication for invasive ventilation. If there is circulatory shock, patient is not easily aroused or alert, there is uncontrolled cough or copious secretions, there is no facial trauma, there is facial trauma, the patient has hematemesis or recurrent vomiting and uncontrolled seizures, only then you are supposed to go for invasive mechanical ventilation. Since nothing is mentioned in this question and it has been mentioned that he is hypoventilating with a PCO2 of 65, the first thing would be to start BiPAP. Okay. All right. Last question. A man was eating food at a restaurant and suddenly started choking and becomes unresponsive. What will be the next step in the management? What would be the next step in the management? Man was eating food at a restaurant and suddenly started choking and becomes unresponsive. What is the next step in the management? Sweetie, you realized after looking at other people's answer that you made a haste. Why? You did not read the question carefully. You thought it's a PYQ. I have read this thing and last year it came and you thought, okay, food choking, I will do Heimlich's maneuver, isn't it? But that is why I told you that next time you are going to get a question, they are going to give you unresponsiveness. And remember, when there is complete foreign body obstruction, then always look at the patient, whether the patient is responsive or not responsive. If the patient is responsive, then you look at the age. Less than 1 year, more than 1 year. Less than 1 year, you go for 5 chest compressions, 5 back blows. But if it is more than 1 year, then you will go for Heimlich's maneuver. You will go for Heimlich's maneuver. But if it is a non-responsive patient, then what will you do? CPR. Yes, I know you didn't see the next option. You didn't read the question also. And that is why it is important to calmly read the question. So remember this thing: in complete foreign body obstruction, you have a responsive or you can have not responsive patient. If it is responsive, look at the age, less than 1 year, 5 chest compressions, 5 back blows. I'll make it this way, not it will be 5 chest compressions, 5 back blows, and then again 5 chest compressions. So they go tandemly. And more than 1 year, you go with Heimlich's maneuver. If the patient is non-responsive, then you will do CPR. And this is a very, very important question. I'm expecting this to be a question in your exam. PQ, potential question. I'm expecting it to be there. Okay. So this is what I wanted to discuss in the Predictor series today. I have taken the most conceptual and the most asked questions in the INICET pattern, and don't worry, INICET is just about a different game of seats. The exam is the same, bearing few questions which will be meant to confuse you. INICET per se is no different from NEET. Only thing that is different is your results. Even if you are a 700 rank or 800 rank, you don't get anything. So the toughness is not in the pattern, the toughness is in the seats. All right. Soumika, you are asking for foreign body obstruction? No. Because if there is a foreign body obstruction at that point of time, you don't really have all the necessary equipments to do a cricothyroidotomy. That is why the guidelines do not say anything about cricothyroidotomy. All right. Any more doubts? Wonderful. So thank you all, guys. I hope you are on the track. My best wishes with you. And I'll see you guys soon on the other side, right? All the best.